It's a very, very big pleasure to be here. Thank you very much for the invitation. It's the first time it's my second time in the center, but first time that I have a talk. So I was very, very happy to receive this invitation and followed it. I will focus on chemotherapy because I was asked to give a summary on the role of pre-op or peri-op chemotherapy in the treatment of gastroesophageal junction. So it's maybe the same picture we saw, but related to chemo and not chemo radiation. So first of all, I think that I would like to highlight that gastroesophageal junction adenocarcinoma is a not very well defined group. So this group became important because since 1975, the incidence of esophageal adenocarcinoma and the incidence of tumors located in the cardia, in the anatomical junction itself, increased dramatically, specifically in men, for reasons that are not completely understood. And this has prompted many investigators to try to establish different classifications for it, and the most important classification used in Germany is the CVAT classification. And the CVAT classification is a clinical classification which consider tumors with their center either between 1 and 5 centimeters above the cardia, in the cardia itself, or in the region under the cardia within 2 to 5 centimeters under the cardia, as tumors of the gastroesophageal junction. But you have to be very careful when you interpret clinical trial results, because in most of the clinical trials in the pre-op treatment, these tumors were considered esophageal cancers, because the classical or the majority of the classifications, apart from the CVAT, they only consider a tumor as junctional if it really physically involves the cardia. But according to CVAT, a tumor here, which doesn't physically involve the cardia, but is within 5 centimeters, is a junctional tumor. So in other studies, an esophageal tumor. So just for one important particularity of these tumors is that seroresection is challenging. So this is a very typical cardiac cancer, and what you see here is that the circumferential part of the esophageal here is no longer sharp, and every surgeon will tell you that this could be challenging at this area. And these are typical pictures of tumors involving the cardia and the esophageal, or of esophageal tumors that are so big that they involve the cardia. And until now, we do not really understand the difference between these tumors. Are these one entity? Are these different entities? I think there are so many discussions and debates on that. The prognosis is bad, if the patient has a T3 or T4, 5-year survival is below 20%. And if the patient has an N1, 5-year survival is below 50%. So, and in fact, I hardly saw a patient with N3 surviving. If you go to the subgroup of gastroesophageal junction, the prognosis is even worse. So this is a group of patients who underwent upfront surgery in Germany, published by Piso. He's a German surgeon. And as you see here, this was a big group of patients undergoing D2 resection or 2-field resections. And as you see here, the cardiac tumors have a worse prognosis than the distal gastric carcinomas. And interestingly, many years later, where probably we thought the surgery has changed, these are results from the FLOT4 trial. with both of the groups pooled together, so these are 716 patients, but not according to FLOT or ECF, just pooled together, junctional tumors have a worse survival. Still, also with neoadjuvant treatment. So junctional tumors are prognostically less favorable, for maybe many reasons. Now coming to peri-op chemotherapy, the first landmark trial to establish pre-op chemotherapy in gastric and gastroesophageal junction cancer was the MAGIC trial. You know the trial very well. 3 cycles of epirubicin, cisplatin, and 5-FU were used pre and post-op versus surgery alone, and survival was improved by 13% from 23% at 5 years to 36% with ECF. And the results of this trial were confirmed by a smaller French trial with 224 patients. So it's half as big as the MAGIC, but delivered nearly identical results with 5-year survival with surgery alone being 24%, and with 3 cycles of cisplatin and 5-FU, so without ibuprofen, before and after surgery of 38%. However, both studies were really different. So if you look at the MAGIC trial was a gastric cancer study, and only 11% were graded junctional tumors and 15% esophageal. But be aware, in the German trials, you will see both groups as junctional. The FFCD Accord trial was a trial that included predominantly gastroesophageal junction cancer. 64% of the tumors were junctional. It was smaller, different regimen without ipirubicin. Interestingly, ER0 resection was improved in the Accord trial, but not in the MAGIC trial. Despite this difference, both of them improved survival. So we don't know exactly why the MAGIC did not improve ER0 resection rate, but probably the patient group is important, because the FFCD trial included those patients predominantly who are at high risk of having ER1 resection. And in this group, you are more able to achieve an improvement, of course, than in gastric cancers. But nevertheless, the systemic effect of chemo was strong enough to improve survival. These trials were followed by approximately 10 negative phase 3 trials, and I would like to highlight some of them. We know that adding post-op radiation to the MAGIC regimen does not improve survival. So adjuvant radiation to peri-op chemo does not improve survival. 4 cycles of ECX are not better than 2 cycles of CF. This has strengthened the impression that we do not need ipirubicin, because it seems that ECF is not really much better than CF. And I think many countries, including Germany and also the US, believed in this for a long time, but now I think we convinced also the UK colleagues of this. What we also do know is that adding bevacizumab, so Avastin, to peri-op MAGIC does not improve any outcome results. And also adding post-op ECF to the adjuvant chemoradiation, to the McDonald regimen or intergroup regimen, also does not improve survival in the intergroup study published by Fuchs and colleagues. So now coming to the first study to show an improvement over ECF, or the first regimen, which is FLOT. We developed FLOT first, in fact, for metastatic patients. And FLOT was some type of modification for the parent TCF regimen that was implemented for metastatic disease, but was too toxic to be used. And we did 2 small studies published by our group, published in International Journal of Cancer and in I think this was Annals of Oncology. And both showed, interestingly, that the triplet consisting of 5-fluorocovorine and oxaliplatin, which is a modified FOLFOX, plus Taxotere, so it's a colon-like regimen with Taxotere, with docetaxel implemented, was associated with remarkably high rates of complete path response we normally do not observe with ECF or CF. So 17.4% in this study and 20% in the other one, versus something between 3.3 and 6% with the older regimens. And this has prompted us to design the FLOT4 trial, where 4 2-week cycles of FLOT, so an 8-week treatment, before and after operation, was compared to the MAGIC regimen. Patients, 716 patients were enrolled, and the primary endpoint was overall survival. And this study showed that, first of all, the complete resection rate was improved from 78% with ECF or ECX to 85% with FLOT, and this was significant. Also, there was a clear downsizing with FLOT, so patients having a postoperative T1 or less, like T0 or TX, because pathologists could not really see the tumor, were 15% with ECF and 25% with FLOT. And this was also highly significant and resulted in an improvement of overall survival by approximately 10%. The median overall survival, I didn't put it here, is 50 months with FLOT and improved from 35 months with ECF to 50 months with FLOT. The path response rate was also improved, but we have this only for the first 300 patients, centrally assessed. So complete path response improved from 6 to 16%, and complete or subtotal, so nearly complete path response, improved from 23 to 37%. And this was published earlier in Lancet Oncology. I think that these results has been also now got support from a Japanese adjuvant trial published at ASCO last year, which showed that adjuvant S1 or that disease-free survival or relapse-free survival was improved by adding docetaxel to S1. And the improvement was striking. In fact, the hazard ratio 0.632. by adding docetaxel to S1 in the adjuvant setting for stage 3, resected stage 3 gastric cancer. It's another situation, but at some, or let us say confirm that docetaxel is a drug that seems to be very effective in early gastric or gastroesophageal cancer. Of course, this trial was driven by the fact that probably S1 mono for a stage 3 gastric cancer is an under treatment. We would go for a doublet normally in stage 3. So now I would like just to highlight some questions that are frequently asked in the tumor board or whatever in terms of peri-op chemo. What about the subgroup of gastroesophageal junctions? Almost all peri-op chemo studies were mixed studies. What's the role of postoperative therapy? Why do the patient need it? And does the Signet cell type benefit? It's a type with poor prognosis in some studies. And what about the FLOT as compared to CROSS for gastroesophageal junction cancer? And I will give some comments on these questions. So let's start for the subgroup of gastroesophageal junction. These are the 3 current landmark trials for peri-op chemo, the MAGIC, the FFCD, and the FLOT. And this is the hazard ratio for the overall population. And these are the hazard ratios for the gastroesophageal junctions population. And what you see here, surprisingly, in the MAGIC and the FFCD, the gastroesophageal junction cancers did better. Hazard ratio 0.49 in the MAGIC. Okay, it was a small group. but a very good hazard ratio compared to 0.75 in the overall group. But also in the Accord, the hazard ratio for gastroesophageal junction was 0.57 compared to 0.67, and in the FLOT it was similar at least, so it was also a bit lower. So what we can say, gastroesophageal junction tumors do benefit from perioperative chemo, as gastric cancers seem to do. In studies versus surgery alone, the effect is even seem to be pronounced. Probably they are more sensitive to chemo because also they are mainly intestinal type and not diffuse type. I don't know exactly. Also, if you look at the subgroup analysis of the FLOT4 trial, which is the largest among these trials, this is the group of gastroesophageal junction, type 1 to 3. And again, probably type 1 is here more the esophageal cancer than the other classifications, but they seem to benefit very well compared to stomach. And I don't have it with me, but there is a breakdown to type 1, 2, and 3, and surprisingly type 1 that had derived the most benefit. This is also, interestingly, if we look at the tumors that had proven Barrett mucosa within them, and the FLOT4 was the first trial to very exactly look at these subgroups. So patients with Barrett mucosa, they were 15%, but they had a hazard ratio of 0.619. So this again give more confirmation that we feel that the higher tumors, although they are from the prognosis, they are worse than gastric cancers, but in terms of their response to chemo, they seem to be a bit better than the gastric cancers. So now the role of post-op therapy. We do know that adjuvant chemotherapy in general has modest activity in Western countries. So in Europe, there were 4 phase 3 trials for adjuvant chemotherapy, and all of them were negative. And meta-analysis just show a 5% increase in survival by adjuvant chemotherapy, so chemotherapy given after operation. And I'm sure this was driven by the Asian groups. So the question would be, okay, if adjuvant chemotherapy anyway is not efficacious, why we do need it within a peri-op concept? The answer is just because David Cunningham did such a sandwich concept in his first study, and all studies, they made it similarly. But there is some additional evidence. Looking at the patients who started post-op treatment in the 3 trials, 55% started post-op treatment in the MAGIC trial, 48% in the FFCD, and in the FLOT trial, there were 60% in the FLOT arm starting post-op treatment and 52% in the ECF arm. So we would say approximately half of the patients. However, it's important to note that these are selected patients. If you look at the reasons why patients did not proceed to post-op chemo, you see that the most frequent reason is progressive disease or lack of efficacy, followed by complications and side effects, and by patient request. So what we can say is that within a peri-op chemo concept, there is a natural selection. So the better patients are the patients, the responding, the fit ones who proceed for post-op chemo. So what we can see here, we cannot exclude that these patients derive benefit from this treatment, because in the adjuvant setting, we don't have this selection. We don't have selection based on response. And this is why currently we do say that patients without relevant post-op complications who tolerated pre-op chemo and had responded should be at least offered post-op chemo. But I agree that the most important component is the pre-op component, and chemo may be de-escalated from FLOT to modified FOLFOX or to 5-fluorocovorine alone if needed. What about signet cell type? This question is important in Europe because the French colleagues, they came a couple of years ago with a retrospective analysis showing that signet cell type cancer cancer patients do worse if they receive neoadjuvant treatment. I didn't believe in this because it was retrospective, but many surgeons, they tended the last years to say, to operate patients with signet cell type cancer upfront. And this is why I like to mention this. The question is, we looked into the FLOT4 trial. What about diffuse? So this is, again, both arms pulled together. Diffuse versus non-diffuse, there was no difference in the prognosis. However, interestingly, only one signet cell made a difference. So the definition of signet cell component in the FLOT4 was at least one signet cell included. So normally you don't see one, you see some cells. And, but this is centrally evaluated. And these patients had really a worse prognosis. So we feel, I mean, this is not corrected to stage. You have to be very careful because probably signet cell cancers do worse, not because they are more aggressive and have more advanced stages, but at least in the whole population, we can say that if the patient has a signet cell cancer in the pre-op setting, the prognosis is worse. However, if you go with this group and look at the relative effect of FLOT, so they do benefit more than the others. And this is also fits into our rationale for oncology, because the more aggressive the tumor, the more you need maybe systemic treatment. You know that these tumors cause peritoneal carcinomatosis predominantly, so they are very systemic. And I think with these results, at least in Germany, every signet cell cancer type should receive pre-op chemo, and there is no rationale to exclude these patients. Now the last question, FLOT versus CROSS. Maybe it's the most difficult one. And I think Karin has very nicely explained the CROSS trial. I will not mention it. I will go, it's very difficult to ask about something like this because we do not have any head-to-head comparisons. So we can compare the trials. What I would say that if you look at the trials, FLOT4 is a stomach gastroesophageal junction trial, so we have approximately half-half, a little bit more junctional tumors. The CROSS trial was an esophageal cancer trial with a subgroup of gastroesophageal tumors. The CROSS was much smaller than the FLOT. It's important to mention this. And if you pull out the squamous types here, you end with a 270 maybe or 290 patients. R0 resection rate was improved in both trials. A very, very bad R0 resection rate in the CROSS and the control arm, but I think this is caused by the squamous cell carcinomas that did not receive any neoadjuvant regimen. But if you look at their R0 resection here, it's nice in both trials with 82 and 85. Complete path response favors the CROSS, there's no question, 23% adenocarcinoma versus 16% with FLOT. If we look at the intestinal type, it's 22% with FLOT, but still this is only a subgroup analysis. We have to mention, I think this is clearly favors, the local effect favors the CROSS. In terms of improvement in survival, the hazard ratio was 0.77 in the FLOT and 0.74 in the CROSS. However, very importantly, FLOT was versus ECF and CROSS was versus surgery alone. And this is also a very important question. But at the end of the day, we have different groups of patients. It seemed also that the patients in the CROSS were generally better because the control arm did also better. I would say that we should look at other features. The pro-peri-op FLOT is that we do have the larger trial, and we have an improvement versus ECF. It's the first time to further improve results against another perioperative regimen. It's important to note this. And we have also the systemic effect. So whenever you feel that I think you need more systemic effect, I think that the fluoropyrimidine and also the triplet could be more efficacious. Pro-neoadjuvant chemoradiation with CROSS is, of course, the less systemic side effects. There's no question. You have less side effects, less neutropenia, less GI toxicity. And also the shorter treatment duration, because if you make pre and post-op float, it's much longer for the patients, more burdensome, and the local effect could be also interesting for the R0 resection in some patients. So now this is, I would like to show you that now I didn't show you anything about molecular-based treatment, but I think that the era after float in the EIO, within the EIO, is now the era of targeted therapy. So this is the current portfolio of neoadjuvant and perioperative trials. All of these trials are ongoing with the exception of the RACE, which will start soon. So for the HER2 positive tumors, we have a trial called Petrarca, where patients are randomized to float with or without trastuzumab and pertuzumab. For the HER2 negative patients, we have the RAMSES, where patients are randomized to float plus minus ramucirumab. For the PDL positive patients, and in some centers also negative patients, we have the Dante trial, where float plus minus atezolizumab, a checkpoint inhibitor. And for the large gastroesophageal junction tumors, we are to start the RACE trial, where both concepts are put together, so float and radiation. But of course, we are not combining float directly with radiation because this would be too toxic. Patients are receiving 3 cycles of float, and the fourth cycles is done with FOLFOX plus radiation, like in your trial. So it's your trial plus the float trial. And we are selecting large patients because we believe these patients are the patients who are more likely to benefit from such an aggressive approach. My summary: perioperative chemotherapy has improved overall survival in gastroesophageal junctions also. In terms of chemotherapy, float is the most active regimen so far. Despite the recent advances, the outcome is still poor. We have to accept this. Also with float, we still have half of the patients with disease, and individualized molecular-based therapy strategies may improve these results further. Thank you very much.